they get up from sitting position. So we give more importance to the claudication distance, unilateral or bilateral. Initially, they present with unilateral symptoms, then over a period of time, progress to the bilateral symptoms as well. We have not been concentrating more on the bowel and bladder involvement. As open surgeons, we used to always look at the MRI, look at the thick ligamentum flavum, and look at the symptoms of the patient and decide for surgery. But then after becoming an endoscopic surgeon, then you start looking at the symptoms in a different way. So bladder involvement is quite important. The post-voidal urine residue, what we find in males and females. So that also gives an indication regarding the chronicity of the problem, as well as the magnitude of the problem as well. So before deciding for surgery, all these issues have to be factored into, and have to be explained properly to the patient, and only then decide for surgery. Not just of course, again, these vary from patient to patient. So some patients they tolerate pain well, and some don't. So your treatment and your has to be based on the psychology and acceptance levels of the patient as well. But broadly, patient will come to you only when they have sufficient pain, which prevents them from carrying out their daily activities. And the bladder involvement is something which you find out and explain to the patient, which again sort of emphasizes your diagnosis and sort of compels the patient to take a decision for the treatment. So these are the things. The symptom wise, what we routinely have been seeing. The extra points which were add is mainly the claudication distance as well as the bladder involvement, and doing ultrasound for a post residual urine is very important. And even for after even after performing the surgery, to check the residual urine again to see whether you have adequately decompressed the neural tissues.
Okay, just one interruption. I have started YouTube live also of this meeting. So all those who are interested can go to that. In the chat window, I have put in the link to YouTube live, and that link you can click and you will be able to see the meeting on YouTube. Now, I would like Girish to take it further and talk about these same issues, his impressions, his perspective. I'll just repeat the issues: the symptoms, the assessment of symptoms, the timing of surgery, the importance of autonomic nervous system and the cauda equina, and then imaging analysis as to decide what we do when we actually intervene. And then we'll take questions, and then we'll take the second part of our talk.
Thank you,
Girish,
sir.
please. Yeah.
Yeah, thank you, sir. Sir, as Dr. Ravindra said that all symptoms already he has discussed, but basically the duration as well as the distance of the claudication. Distance is very important, as well as the weakness. I always suggest, I always look for any weakness in the foot or the foot drop. So the symptoms wise, the claudication duration as well as the bladder and bowel involvement. Many times the patient comes with only the radiating pain and the claudication, but he or she is not favoring the favor of the surgeries or the other symptoms. So I always prefer for the PVR, post-void urine, in the ultrasonography. If the patient has the post-void urine more than 100 ml, then I teach him or I taught him that you are already on the risk factors. So I always suggest that we should measure the post-void urine for regarding our legal point of view, as well as for the patient point of view, that he is not he's not like that the symptoms is not serious or the severe, but according to the seeing of the post-void urine, we can judge that how much on the patient is on the risk. So I will add one more thing, that the post-void urine is the most important, and which will be seen in the ultrasonography always. So I suggest that the patient is not taking the serious point in the claudication as well as the other methods. Many times the patient says that, sir, I am doing all my daily activities and I am tolerating it. But I always suggest that we should go for the ultrasound for checking the post-void urine. So according to the symptoms that Dr. Ravindra already covered the all symptoms, I'll suggest for the post-void urine here only.
Yeah, I would just add one or two things here. Number one is our traditional understanding of lumbar canal stenosis was only claudication. It is not true. We will have mixture of claudication, we will have radicular problems, we will have weakness, motor weakness, and very important is all these things will be there because we have now better understanding of the lateral and the anterior causes of the symptoms. These causes could be osteophytes at the end plates. These causes could be partially healed annular tear with a loss of concavity of the disc causing hardening of the disc. These causes could be soft tissue hypertrophy in the foramen and overriding of the superior articular surface when the disc is slowly collapsing. So there would be some radicular pain or radicular-like pain in addition to claudication in some of the patients. The second important point is some of these symptoms are present even at rest. Especially it has been noted that if you're dealing with a L5 stenosis, pure stenosis involving the L5 nerve in the foramen of L5S1, then many times the patients do have pain at rest, even at night. We also have a symptom which is very unusual, that is patients have pain in the calf, very severe, especially at night or early morning around 2 o'clock when the temperature outside is quite low. So this is also one more symptom which is also very commonly seen with stenosis. And one more thing important about these symptoms at rest. It has been seen that if you see symptoms at rest in the form of numbness, then it is very, very likely that this numbness at rest will not go away. It may remain permanently because it indicates some change in the nerve function, which may be irreversible. So these are few additions to that. Now, if there are any questions, please ask your questions by unmuting yourself. And then we will go on to some more part of our talk. And then we again talk about the basic things which we have just covered. So you can sort of unmute yourself and ask question. If it is taking time, you can put it in chat. I can read that question.
Sir, may I ask?
Yeah, please.
So after these 4 horizontal levels that we have seen, you have further classified each level into anterior, midline, and posterior. Now, can you tell us
not midline, anterior, lateral, and posterior.
And posterior. Okay.
Yes.
So as per your experience of large number of cases,
yes,
can you quantify into each? Let us say blue zone, anterior is approximately 30%.
Yeah, I would tell you that as far as our experience is concerned, it is always a mixed presentation where we have anterior, lateral, and posterior in almost all the patients. The only difference is the exiting nerve is involved more with the posterior cause of ligamentum flavum in the upper part of the foramen. The disc causes, that is the end plate causes and the collagenization of the disc and loss of concavity related causes, which are anterior, generally come with the disc herniations or older disc herniations coming up again with some new annular tears, etc. The lateral causes, that is the causes in the foramen in the form of hypertrophic tissue or a knot, knot of tissue in the foramen, are also very common with disc herniations. And the posterior causes, that is hypertrophic tissue subfacet, that is in the lower zone or the extreme lower zone, are very common as the posterior causes. Now, let me make a clarification here. The clarification is, if you draw the lines vertical in the coronal picture, that is one line which is medial pedicle line and the second line which is midline. And if you look at the image very carefully, you will find that these, just give me one moment. Somebody is raising some question. Yeah, Karthik, I'll answer your question. Just give me a moment. And listhesis instability related at what level? Listhesis, we are not talking today. just to keep the clarity in the discussion. But I'll take your question, Karthik, now so that it is more clear. When you say anterior compression, does the symptomatology change? Yes. Please listen carefully. When we see these patients, many of them say that they have this pain on the back of the thigh, which increases with walking or with standing. There's a simple differentiating thing which I have seen in clinical practice, and it is you make the patient stand and extend the back, that is, do the back extension. If the causes are posterior and subfacet, with extension, the symptoms would increase. The severity of the symptoms would increase, and the patient would say that I cannot extend, or the extension is increasing my symptoms. Where you have causes which are anterior, that is osteophytosis or loss of concavity of the disc or hardening of the annulus, then you will find that with extension, the patient says, oh, I feel better. My symptoms are less. Now, the presentation is claudication, but with extension, the patient says, I'm much better, which is indicative apparently of anterior causes. Now, I'm open on this point. I would like all of you to try this and come back and say that, yes, it works, or say that it doesn't work. We are open about it. We know that we are not the final word in all this, because all of us are trying to take out better meanings of what we see in our practice. Now, Varun is saying, can stenosis due to posterior flavum be tackled by transforaminal as opposed to foraminal? Okay, I'm coming to that itself. Can we classify LBP as a symptom when there is severe stenosis, engorging vessel, signs of ischemia? Yes, we can. Low back pain is also part, but commonly in stenotic symptoms with low back pain, it is attributed to micro instability. We may have to also pay attention to this engorged vessels and venous congestion, etc. There is a definite role for that increased venous pressure, and there is a definite role in our traditional system of medicine where multiple enemas were given to people who had stenotic symptoms with signs of venous congestion, etc. There was a time in our learning process when we were residents where we used to do epidural venography, etc. So all those people who had increased epidural pressure, venous congestion, used to be relieved after they had been to the toilet in the morning, emptying their bowel, reducing the venous pressure, etc. So there is definitely a role for that. Now, about a question which Varun has asked, let me clarify. If you go through the definition of stenosis, the traditional outlook is that all of it is posterior, everything is posterior wall of the canal, and you remove the choice part, your choice part of the posterior wall, which could be lamina, could be this edge of lamina, that edge of lamina. Some people would remove the medial aspect of the facet, but all of them would probably remove the central middle part of the ligamentum flavum. Now, if you go by the definition, I will tell you my definition of the canal in cross section of the posterior wall is there is a part which lies between the medial pedicle line and lateral pedicle line roughly, which is foraminal. The second is between the medial pedicle line and a line which could be roughly midway between the midline and the medial pedicle line. Now this line on the X-ray would be at the medial border of the inferior articular process. Or you can say this will be the lateral border of the interlaminar window. This is a subarticular area, especially in the lower part of the foramen. And the third area is the line that is midline of medial pedicle line and midline. Am I clear on this? And the actual midline of the canal. I would repeat this. The area between the line which is drawn between medial pedicle line and midline of the level and the midline. This is the central area of the canal. Now, this central area of the canal is the one which is occupied or which is populated by the ligamentum flavum, and unless the disc is collapsing, which is indicated by the superior articular process overriding the inferior end plate of the upper vertebra, there is no reason why we should touch this ligamentum flavum. Now, all of you would agree with one point, that in these patients, if we jack up the disc, if we put in an intradiscal spacer or an intradiscal cage, whatever way, through the foramen, T-leaf, whatever, you are jacking up the disc. The moment you are jacking up the disc, the posterior central ligamentum flavum becomes irrelevant as far as symptom generation is concerned. We do not have to touch that ligamentum flavum. Number two, there is no evidence anywhere in the world literature to talk about pure central stenosis except the congenital or the ones where the pedicle is short. And I will tell you that there are several publications which now are appearing in the transforaminal endoscopy domain, where people say that they treat central canal stenosis, but they make a trick. They define the central canal stenosis by saying that the definition is when the anteroposterior diameter of the canal is less than 10 millimeters. Now that is cheating. We are no way treating the bony canal here. Now, Pawan, you're saying that classical neurogenic claudication is known to be relieved by forward flexion. Does this mean that all are anterior? No. The ones which are relieved by forward flexion, which gives that posture to the patient, inability to extend, are all foraminal, are all facetal. Please read your question again. Classical neurological claudication is known to be relieved by flexion. Does this mean that these are all anterior? No, these are all posterior. The pathology is in the foramen on the undersurface of the facet, which limits the extension, so they feel better with flexion. Okay, can we go ahead? Or ask your questions. We can have questions, not an issue. Karthik, did I answer your question? Because you are an important person who should be satisfied. I mean, I know that your experience with this access and traditional access to the canal, etc., is also very important. I'd like to know your perspective.
Yeah, you are very, very clear in what you're what you have said at the moment. I don't think there's any ambiguity in this at all.
Yeah.
The only thing is, to teach youngsters is to differentiate between the symptomatology when there's an anterior. Now, what is similar to what I'm saying is, it is something like your retrolisthesis and your spondylolisthesis. A person with a retrolisthesis oftentimes has worsening of pain on extension. On flexion, not on extension. So you often tell them to do an extension exercise as compared to somebody with that so-called posterior occlusion leading towards the pain on extension. So this is something very similar to it. And I think the understanding has to be very clear to all of us in that.
Yeah, I would say that since we operate our patients under local anesthesia, we have seen this on table also. You ask the patient to extend the back on table under local anesthesia when you are in the foramen, and you will find that all those who have a cause in the foramen, I mean towards the foramen, let us say subfacet and foraminal, will always have pain going down the leg on extension. And if the cause is central, that is central anterior, then there won't be an increase there. Of course, let us not mix disc herniations with canal stenosis. I know that we will have to have some more clarifications on this. Now, Dr. Vyapak Paudel is asking, what is your perspective when the patient presents only with gluteal pain? I have seen gluteal pain commonly just behind the trochanter, and it is constant. I've seen it to be because of stenosis at L5S1. But again, I will say that since I operate under local, I have probed this area, and I will tell you something which is very surprising. If you probe the nerve, when you're doing endoscopy under local, the body of the nerve, it gives you pain going down the leg, pure radicular, well-localized cutting sharp pain. If you go on the inner border of the nerve towards the axilla, then the patient gets more of back pain, which could be similar to this. If it is little distal part of the nerve, it would be more going towards the gluteal area or the buttock area. And if you go purely on the traversing nerve side of the axilla, it is more of back pain. It is not leg pain as such. Now, these things have to be done. These things have to be taught. These things have to be brought into discussion with more and more people operating under local. Then I think we will have a consensus on this point. Otherwise, we are just repeating and recycling the information which probably our grand teachers have put in our brain and which comes from studies pre-MRI era, which come from studies of cadaver dissections, which comes from studies of myelography, and which comes from studies of surgery for stenosis. And the standard surgery has been wide laminectomy. I will not agree with that because there is no evidence to show that the posterior neural arch and the ligamentum flavum in the midline causes any of the symptoms. I do not agree. Show me one single paper, not by exclusion. Show me one single paper which will positively show you that these symptoms arise from the posterior midline structures and these structures alone cause the symptoms. Let us work on that. I mean, we have 2 more projects where I would be needing all of you to contribute to that project over a period of time. We will talk about it a little more once we go to the next part of our presentation. Now, Karthik, flaval hypertrophy as demonstrated by measurements as cause of stenosis. Okay. I would say that in these papers which have measured the hypertrophy of the stenosis, I mean hypertrophy of the ligament, they have never mentioned about whether the disc has collapsed, whether the disc height has reduced, etc. I, for one, I believe that when you have a collapse of the disc, you will always have the bulge of the flavum. The flavum in the midline anyway is deficient, pure midline. If you go little on the outside of the midline, say about 2 millimeters from the midline, and then you go to the medial border of the facet joint, this is the area which should be called as a central area. There is nothing which gives symptoms in this area. There have been various papers about epidural or dorsal epidural space, dorsal to the dural sac, and whether it can cause symptoms, etc. You see, in medicine, we know that nothing is unknown, but commonly this is not an area which causes symptoms because there is no neural tissue. The problem is, what has happened is people have been showing different images and talking of different symptoms. Let me clarify what I'm saying. I will talk of symptoms which are arising from the disc zone. That is where the cause is in the disc, the posterior wall, where the concavity is lost. There is a bulge, there is a collagenization of the disc. But when I talk of the image, I show the lower zone of the disc, where I have that V of the lamina, and then I say this ligamentum flavum is causing the problem. Absolutely no. I'm sure that if you go through the classification which we are talking, we are extremely clear to the millimeter about what area is causing what problem. Now, at the end of our talk today, I'm going to put a quiz to all of you, which will clarify some of the concepts and some of the confusion which we are having in our mind. Now, let me tell you that when I started doing transforaminal endoscopy for disc herniation, half of the population of our country was not believing what we were doing. They said, you cannot operate under local. You cannot operate for migrated herniations. You cannot operate for major migrations, etc., etc. Now, all that has been a talk based on ignorance. There was nothing known to these people who were just trying to show off that they knew everything about this surgery, which was not the truth. Once we started demonstrating in all our conferences with live surgery and show that the patient is really awake and aware, and we are doing the surgery actually in an awake and aware patient, I think the people started understanding and changing. Otherwise, the whole nonsense would have been continued even now where people even today talk about going interlaminar, etc., etc. I don't want to dilate on that point, but what I'm trying to say, our understanding of the problem is far, far clearer, and we are open. If you have any comment or you want us to sort of change or you want to modify what we are saying, we would like to understand and talk with you. Now, where is the place for it in 2020 in the diagnosis? No, this is not the place to talk about that paper. Anand, you are saying paper sciatica detection confirmation by new method. Where is the place for it in 2020 in diagnosis? I will explain to you later when we talk about sciatica, etc. But I'm going to come back to that paper when I'm going to talk now about further part of our study. Any more questions before we go for the further part of our study? Ravindra, you have any comment? No, unmute yourself, Ravindra.
Yeah, regarding the imaging, maybe regarding the importance of the coronal oblique images, MRI images, and for the types of ligamentum flavum, we have 3 types of ligamentum flavum that also add to the diagnosis and as well as the treatment.
Yeah, okay, I wanted to keep it as a secret for today, but okay, there's no secret in it. Let me mention. Karthik, we have gone through the literature extensively, and there are multiple papers which I can send you where I can convince you that the ligamentum flavum, which really causes a problem, is very, very different. Let me tell you that there are 3 types as described in the literature for ligamentum flavum. Type A is ligamentum flavum, which is between the midline and the medial border of the medial facet. That is the interlaminar window. Type B, that is the extension of this ligament, is below the facet, under surface of the facet, which is the ventral capsule and the facet capsule amalgamated with the ligamentum flavum. And it goes, let us say, up to medial pedicle line, little outside that medial pedicle line. And then we have the type C ligamentum flavum, which goes right up to upper pedicle, and it continues outside the foramen as intertransverse ligament. Okay, so we already know this. There are multiple dissections which we have done. I have also done, and there are papers which talk about this image exactly. That is the ligamentum flavum extending from the midline to the upper pedicle going out of the foramen. Now, this has been assiduously ignored by the traditional surgeons to their loss. We have nothing to say on that matter. If you want to say that the anatomy is not like that, it's okay. I mean, everybody has a right to his opinion, but science doesn't change by opinion. Science is based on observation, confirmation, and repeat confirmation. Now, about this ligamentum flavum hypertrophy and buckling, I will tell you that if you look at the, let's say this, what I'm showing, if you look at the functional spinal unit, what are the moving parts of this functional spinal unit? The only moving part of the functional spinal unit is the disc in the front and the facet joint at the back. The disc in the front undergoes changes of annular tear and loss of concavity of the posterior annulus. There is a bulge, there is a filling up of that concavity, there is osteophyte formation, and there is a osteophyte at the upper and lower end plate. So these things are happening in the front. At the back, what you have is the facet capsule is hypertrophied. The tissue which covers the facet capsule, that is the ligamentum flavum, also hypertrophies and causes foraminal compression or causes foraminal stenosis. Now, if you talk about the buckling is seen with the collapse of the disc, as has been mentioned by Dr. Varun Agarwal. So when the disc starts collapsing, what happens is, look here again, when the disc starts, I don't know, are you able to see? Okay. When the disc starts collapsing, you will find that the SAP will go up. The SAP will go towards the upper pedicle, and then it will cause a narrowing of the foramen. In addition, because the disc collapse, there is a buckling of the ligamentum flavum. So only when the disc height is reduced. Now, how do you know that the disc is collapsing? You draw a line around the lower end plate of the upper vertebra. And if the tip of the SAP is crossing that line, it means that the disc is collapsing. Then there is a point in talking about the real central part of the ligamentum flavum, which anyway can be stretched, can be jacked up with the disc, can be stretched. There are multiple papers about what is the effect of jacking up the disc on that ligamentum flavum, which we can always discuss as a journal club next time maybe. So I would suggest that let's have another meeting next time where we'll talk only of ligamentum flavum. And I can show you at least 8 very, very significant papers on ligamentum flavum, which have been ignored by the traditional surgeons, where they just say, oh, no, 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 it's not like that. I mean, it's pathetic. I would feel very sorry for those people because they want to ignore that just because they have an agenda where they want to put particular screws and do whatever surgery which works in their hands. I'm not against that surgery. I'm against this attitude towards ignoring the reality in science. It is not something which I have created. It is something which God has created, which we have studied. I mean, lateral part of ligamentum flavum is a reality. Please be aware of that. And the next meeting we will do on ligamentum flavum alone, nothing else but ligamentum flavum, and how to go for this part of ligamentum flavum and that part of ligamentum flavum. And one more thing which I'll tell you, which will probably surprise you, is that from the literature and from our experience of transforaminal access in all our surgeries, I would say that in all probabilities, the lower part of the foramen is empty of ligamentum flavum. It only has foraminal ligaments. Yes, what you say, Karthik, is correct, that when we do an interbody fusion, it gives a decompression and it also makes the ligamentum flavum stretch. So the jacking up of the disc definitely makes the ligamentum flavum as tight as it was before. And what is the treatment for multi-level stenosis? Okay, I do agree with that question, but today we are trying to keep it simple, trying to restrict to one level. Multi-level deformities, instabilities, anterolisthesis, retrolisthesis, lower foraminal problems, we will discuss one by one. I think ligamentum flavum per se also is a big topic. So in this simple basic presentation on lumbar canal stenosis, what we are trying to do really is to bring to your attention that it is not only the posterior wall, but it is like a C on both the sides, anterior, lateral, and posterior. Anterior, lateral, and posterior. So it is all around the dural sac, and the anterior is the disc, the lateral is the foraminal hypertrophic tissue and the tissue knot, and the posterior is the hypertrophic tissue subfacet area, lateral races in the lower part, ligamentum flavum in that part, whatever. So a posterior decompression alone is not sufficient. And we say that since we are going through the foramen, we are able to tackle all these causes, anterior, foraminal, and posterior causes at the same time. And we have been tackling the disc causes all these years. We know exactly where is the osteophyte. Now, is the peculiarity for pain arising from end plates? Okay, you see, Vyapak, the problem is there is a long list of literature about end plate changes, which have started with description very well by Modic. And Modic says that the changes of inflammation in the disc probably cause and contribute to the back pain. I, for one, I normally treat it with oral anti-inflammatory because these pains are not very severe. But I have a colleague of mine, if you want, I can put you through to him. His name is Dr. Sarju Bhagia. He is stationed in New York. Maybe not in New York now, but he is stationed in US. And these people do a vertebral denervation. You must be aware that there is a nutrient artery and a nerve to the vertebral body. So if you do a vertebral denervation, you will be able to relieve the pain coming from the vertebral body or coming from the end plate. I hope that answers your question. Yeah, Neeraj, you are asking me to enlighten on the pathophysiology of ligamentum flavum that I have kept for the next meeting, because it's a huge topic. I can tell you that, yeah, everything, MRI picture of anterior foraminal posterior stenosis, I can show all of that, but not today. Today we'll go ahead now with our other part of the write-up. I think, where is it? Now, just give me a moment. I will show you. Okay, so I will be now sharing this part. Okay, are you able to see what I am showing?
Yes.
Yes. Okay.
Yeah.
So I'll just repeat these images for a second as to clarify what we are talking. So this is a standard image where we land in the foramen here in the Cambin's triangle and work under the superior articular process and the posterior annulus at the posterolateral corner of the disc. Then this is to clarify that this is a plane which we draw at the lower end plate, which divides the foramen into upper foramen and lower foramen. Then we go for upper foramen where you are below the pars, not the SAP, it is pure pars. And this is where you have the hypertrophied ligamentum flavum going to the upper pedicle. Now, mind you, in the upper foramen, you have the dorsal root ganglion, and cephalad to the dorsal root ganglion, you have the segmental artery. So we never go cephalad enough in the upper foramen. In the upper foramen, again, this is a coronal oblique MRI image where this blue arrow is at the facet joint level, and a part of the ligamentum flavum above the blue arrow to this pedicle is the part which is the roof of the foramen or the subfacet area. This is the lower zone that is below the lower end plate up to the mid cross bisecting line of the pedicle. This is subfacet zone, and this also need decompression in decompression of the traversing nerve. And we have this lowest zone, which is inside the pedicle, which all of us who do endoscopy have been tackling for down migrated herniations by doing a medial or the oblique pediculectomy, etc., etc. This is an all bony zone of the canal where you have this area, the blue area, which has the stenotic elements. Now, I'm coming to a very different topic now, and all of you who are interested, you can contact me here on chat or send me a mail. My email is very simple, drgoreonline@gmail.com. I'm talking about conservative therapy of lumbar canal stenosis. Now, all of us know that there is hardly anything in conservative therapy because there's nothing which has been found to be consistently helpful. What I have found is there are two things which are helpful. One is the stimulation of the nerve distally. That is at the point which I have described in my sign, where you have the lateral terminal branch of deep peroneal nerve in the roof of the sinus tarsi, and you have the sympathetic chain paraspinally in the spine, in the back, where you know that everything related to the lower back goes to the brain through the L2 nerve root and the ganglion there, the sympathetic ganglion paraspinally. So it has been found from literature, out of which I'm quoting two papers here, which say that if you stimulate the nerve distally or you stimulate the sympathetics proximally, you may have an increased blood supply. And let's go to these two references. The last reference, that is the second one, is TENS augments blood flow in the somatotopically linked spinal cord segments and mitigates compression ischemia. So this is a hypothesis that this may help in relieving claudication in patients without surgery. And the first reference is effect of peripheral stimulation on blood flow of the spinal cord and the nerve root. Now, let me tell you my experience. Whenever I have used the distal block, which I call as my sign, gore sign with distal block at the sinus tarsi or on the lateral wall of calcaneus for the sural nerve, I have always found that there is an increase of local skin temperature to the extent of 3 to 4 degrees Fahrenheit. Now, this is the definite sign of sympathetic effect or vasodilatory effect, where in the past we have been doing sympathectomies to achieve vasodilatation in TAOs and distal toe related gangrenes. So now I'm going to tell you about two things. One thing is called as Dr. Stim app. I hope you can read it here. And the second thing is called as 6 minutes WT or 6 minutes walking test and variations on the use of mobile. Okay, are you able to hear me well?
Yes.
Yes, sir.
Yeah. So this Dr. Stim app is an app which is prepared to be used with a distal blocker. Now this distal blocker is like a piece from the carom. All of us play carom. So those round pieces, it is a little bigger than that. It has a battery in it. This can be put on the skin. The patient can walk around. It is wireless. And this app, Dr. Stim app, is in the mobile phone, and the patient can use the app to stimulate the nerve at will whenever the patient wants, in presence of numbness or in presence of pain. I will talk about this in little detail with the questions if you ask. The second is the 6 minutes WT, that is walking test. Now, this is a very simple test which recently has been brought in the literature as a simple way of assessing people with lumbar canal stenosis. So what we do is very simple. You ask the patient, nowadays most of the people have a mobile phone. So you ask the patient to download this 6 minutes WT, which is free on the Google Play app. And you get the app and you start it and you start walking. And you measure the number of steps which you walk in 6 minutes. Now, what is the importance of 6 minutes? There is apparently no importance, but empirically that value has been chosen by the study group which used it the first time. You can put any limit. What I do is, I will tell you, I ask the patient that please start measuring the steps which you take while you are walking. And the moment you start getting numbness or pain or heaviness or inability to walk further, you know or you note the number of steps. Then you start the treatment and you do this every day, every third day, every second day, every week, whatever. And when you come back to me, you show me what has happened in the number of steps which you take. Why we have done this 6 minutes is it is easier to remember, and almost everyone who, even though suffering, can walk 6 minutes. So you have 6 minutes, measure the number of steps, and use this Dr. Stim app on the distal blocker, which is put either distally on the ankle, anterolateral, posterolateral to the ankle, or you put it paraspinal to stimulate the lumbar sympathetic ganglia and see the effect. Now, the next question is, what is the intensity and what is the duration of stimulation? This you may have to find out by trial and error. But I have been putting it for the males The intensity is around 8 to 12. You will understand it on the app, and the duration has been up to around 20 minutes or 15 minutes onwards. So once we start doing this, then I want anybody of you, any one of you who wants to sort of help us in this study, I will give you the digital blocker sort of on rent. You just pay 1 rupee rent, and then you treat your patients conservatively, you collect the data, we collate the data, and we publish the data. That is distal stimulation of the nerve or proximal stimulation of the paraspinal area with an electrical stimulation with measurement of the steps and the time the patient can walk and the result before and after. Now, coming to the last part of my talk, just 2 or 3 more minutes, and then we will again go back to questions. So what now we are going to talk next time is going to be a free meeting, not paid meeting. I have written here paid meeting. I'll tell you what that means. And there we'll talk entirely about pathophysiology of ligamentum flavum, the structure, the anatomy, the classification, the cadaver dissections, the imaging, and the pathophysiology, how it affects the axilla primarily. I would only say that all of us who have been doing endoscopy transforaminal in the upper foramen, mid foramen, and lower foramen are capable of treating lumbar canal stenosis. The main thing which is lacking today is proper tools and proper ability to visualize all these structures. And that is where is the importance of our cadaver workshops now onwards, our workshops where we'll be giving detailed step-by-step instructions about what we do. And new tools and added modalities of treatment like flexible drills, curettes, which are already available, and a new thing which is coming up, which is what is called as a RF cannon, which I've devised with one of the companies, which is a RF, where the probe, the handpiece, that is the thing which we put inside, has 7 or 8 dots on the tip. So it literally, you can say literally puts out fire, not only RF stimulation, fire, which can entirely take away the soft tissue which you are working on. I would also like to tell you that because of the number of hours to be spent, the efforts to be spent, etc., some of our meetings hence onwards are going to be paid meetings. Those who are interested can join. Now, let's go back to question answers. And before that, I will like Girish and Ravindra to have their comments on this second part, which I just talked about, and then we go for question answers. Questions can be asked by unmuting yourself or by putting in the chat. I can read and I can ask the proper person, or I will try to answer. Before I forget, before we end, the next meeting in coming 3-4 days time would be entirely on ligamentum flavum. And I assure you that we have something which you have never seen, heard, imagined. I will guarantee you that this is something will entirely change your outlook towards what we are doing today about the ligamentum flavum thing. I can tell you that I have gone through all the possible literature recently and 2 months back and 6 months back, and I have collected all the papers related to ligamentum flavum, which unfortunately are absolutely not what we think about. So we will talk more about it next time. Now I'll ask Ravindra and then Girish to give your additions and comments. And if Faisal is here or Janmeja is here, I would like him also to join. Okay, Ravindra, please go ahead.
Yeah, thank you, sir. Again, as pointed out by you,
no, please unmute yourself. Ravindra, please unmute. Yeah, okay. Okay, go ahead.
Yeah. Regarding lumbar canal stenosis, it was always a sort of involvement of the central canal. Whenever we look at the MRI as well, it used to be the ligamentum flavum, the central part of the ligamentum flavum. And we always used to concentrate on the diameters, and based on that, and of course on the symptoms, is to take the decision as to operate. But again, the importance was given to the clearance of the central canal, and of course decompression of the subarticular part of it as well. But then how much we removed, to which area which nerve roots we decompressed, there was always a question mark on that. Primarily, the importance was given to the decompression of the central canal alone, and we used to take out a ligament under the medial facet. But then later on, with our endoscopic pictures, we could find out that that's not the portion of the ligament which was actually causing the symptoms. It was a portion which was more lateral to that, as well as the superior articular process. So we're unable to reach that area from inside through an open, which is causing.
Your voice is cracking, Ravindra. Could you please repeat the last sentence? Ravindra, your voice is, you are frozen.
Okay.
No, you were frozen. Please repeat what you said last.
Okay.
No, you're muted now. Please unmute. Okay, unmute. I am unmuting. Okay, fine. Yeah, go ahead.
I'm getting some calls. Hello?
Yeah, go ahead.
I'm audible, sir? Yeah. Flavum, which the central part of the levatum flavum as well. But then now we after performing endoscopic surgeries, now we have understood that it's not the central portion of the levatum flavum which is the causating factor. It is mainly the lateral part of the levatum flavum, which is in the foraminal area and the subarticular part, which is the actual reason for producing the symptoms. Our hello.
Yeah, go ahead.
Our focus has moved on to the actual portion of the levatum flavum which is causing the symptoms, rather than a sort of an indirect decompression what we were doing all these years. So through the transdermal route, we can visualize the levatum flavum, but of course, it is not so easy to remove the flavum which we see. So it requires special instruments and experience, and we need to do many cases to give better results. So that's the only roadblock I feel. Whereas with experience and with many people joining in, I think we can definitely change the way lumbar stenosis is treated in future.
Yeah. Now, before Girish, you go ahead, I would like Janmejay to have his comments because he has been keeping quiet. Janmejay, please. Yeah.
Yeah. Good afternoon, sir.
Yeah, good afternoon.
So
you can
as
have
you
your
had
comments on symptoms. You can have comments on the autonomic part, the cauda equina part, the timing of surgery, the image analysis, and your perspective on this issue.
So I think you've already gone through this regarding the symptoms. It is mainly claudication symptoms, and for claudication, pure claudication, I suppose the patient needs to decide if they have no other neurodeficit or if they have only slight weakness in the limbs, which is not affecting their daily activities, then they get to decide when they can or cannot get operated. But obviously, if the bowel or bladder starts getting involved, which we can only find out with the post-void residual estimation, then it becomes a necessity because there is a chance of permanent neurodeficit in such cases. Secondly, regarding the treatment, I think there is still a role of steroids and epidural steroids in these cases, because there is definitely, it has been proved that there is a role of inflammation in lumbar canal stenosis as well, and many patients will do well for some time at least with steroids. Obviously, if the effect does not last long enough, or if it does not have any effect at all, then you need to consider surgery if the patient is in that much pain as to merit surgery. And regarding surgery, I think we had talked about this. I think the instruments right now, at least those that I have right now, seem to be a limitation to the amount of, or at least to the amount of ligamentum flavum you can get, or at least to the amount of time that it takes to get out a small amount of ligamentum flavum from the transforaminal approach. So I think those are some issues which need consideration. consideration. But I think I'll try the curate which you said. Once this lockdown ends, and hopefully that problem of mine will be sorted out.
Correct. I think with better instrumentation and additional ability to visualize where you are doing it would definitely improve. I think there would be a better role for cadaver workshops now onwards, which will be entirely devoted to lumbar canal stenosis rather than discectomy, because I think we now have enough expertise and enough information about Now there's a question for you, Janmejay, regarding epidural. What is your experience about the route? Do you give it transforaminal or interlaminar?
So usually patients will present with unilateral symptoms most of the times. And definitely the amount of, if you give a transforaminal injection, the drug is much better concentrated where you need it. With epidural, the spread is unpredictable. So I would definitely say transforaminal route.
Yeah, Karthik is asking you, don't you give caudal epidural?
I do give caudal epidurals, but I think transforaminals are much more effective.
Yeah, I would add one or two small points to that. When you are giving transforaminal or interlaminar or caudal, in caudal and interlaminar, most of the times it is given blind. I mean, the interlaminar is given like a spinal injection where you depend on the test of sudden loss of resistance when you push the air inside, etc. And the caudal, it is blind because you feel that you're already in that foramen or the caudal opening there, so you will definitely go where you want. But many times we have seen under image that the catheter which you put may not go ventral to the dural sac, but will go dorsal to the dural sac. So it may not be very effective. Now, there is also a, I would say, intentional confusion in the mind of a lot of people who follow the pain management ideas, where they have their own safe triangle, which is between the exiting nerve and the upper end plate of the vertebra towards the pedicle, which is nonsense, which should not be done because the segmental artery is there and the vessels are there. And there are reports in literature, even in India, we had a patient in Indore who landed up with problems with paresis and a lot of complication just by embolization when the injection was given in that alleged safe triangle above the exiting nerve root. Now there's one more question which somebody is asking: lateral recess block, exiting versus traversing. Now you see, all these questions are immaterial. When you're in the Cambin's triangle and you're towards the axilla, you can cover both the nerves by rotating your nerve with the bevel pointing towards the exiting and bevel pointing towards the traversing. So it's not difficult to do that. In addition, if you want, you can always do an epidurogram by injecting dye in that area in the axilla and confirming where you are, and then you inject. If you ask me personally, I give intradiscal injection mainly, especially in disc-related problems, because that is where the pathology is, and steroid will leak the same way like the cytokines. But in case of stenosis, I would agree with Janmejay, and I would give a transforaminal epidural towards the exiting nerve or the traversing nerve, mainly the traversing nerve. Okay, so what cocktail you use and volume? Janmejay, what is the cocktail which you use and what is the volume?
Actually, I was just typing it out, sir. So it's
okay.
But no problem. It's 1 ml of 0.5% bupivacaine and 1 ml of 40 mg per ml Kenacort. But I think it is safer. It is even safe to use up to 2 ml of 40 mg per ml Kenacort. And I don't. I think it is better if we do not dilate this with any other component. I think this should do. Just bupivacaine and Kenacort. Triamcinolone acetonide particulate is good enough.
Yeah. Neeraj is commenting that it will also depend upon the cause of stenosis, if it is anterior, discal or posterior. Yeah, it is true. But you see, Neeraj, what is happening is all these finer points or fine tuning will happen once all of us start using this jargon and all of us start agreeing on these points, what we are treating. I mean, if I talk with a very, very standard, pure traditional surgeon and ask him what you are treating, probably the restriction is we will talk only about the posterior causes. If you talk with somebody who is doing a transforaminal surgery, he would probably talk also of lateral and anterior causes, but will express the difficulty in reaching the posterior causes. So that, I think, the narrative which the traditional surgeon has and the narrative which we have are different, not because the science has differed, but because our perspective is different. We are looking at it through the foramen. You are, I mean, some of you are looking at it through the interlaminar area. There's nothing wrong or right, but as Janmay or Ravindra also has emphasized, our surgery we feel is more direct decompression of the structure involved, and the traditional surgery seems to be indirect decompression of the structures involved. So let us go ahead. Now, I would like Girish to have comments on these various things which we have raised, and we go ahead with question answers simultaneously.
Yeah, thank you, sir. So
Yeah.
basically, I think that we can only differentiate when we will diagnose the exact pathology. Most of time, the conventional surgeon what are doing, it's my personal thought that what the conventional surgeon is that they do the surgery all structures posteriorly, like the lamina, facet, and the ligamentum flavum, hypatoid, ligamentum flavum, all structures removed. Then go anteriorly by removing the disc and use the instrumentation because of that they have done the facetectomy. The conventional surgeon never reach up to the foramen without the facetectomy. So what is the basic problem that when they do the facetectomy, they need to the instrumentation to stabilize the spine. So when we know the exact pathology, that where is the pathological structure, either is the superior part, upper part of the foramen, or the lateral or the lower part of the foramen, what you told. So we can do by the transformal technique, by the very precisely. So it's a very good that we can do the all surgeries by the transformal, even the canal stenosis, and we can deal the anterior as well as the lateral and the posterior structure. While the conventional surgeons can't never do without facetectomy to the lateral as well as the anterior pathology. So I think the transforaminal surgery we can also, as well as we and you progressing with these type of the surgeries. Thank you so much, sir.
Yeah, somebody is asking the same question again. How can you differentiate between the disc related cause from the canal related cause? I mean, disc herniation differentiate from stenosis. So the answer is very simple. Traditionally, the canal stenosis understanding has been posterior causes, mainly the foraminal causes or the facetal causes with ligamentum flavum hypertrophy on that area. What we do is we ask the patient to extend the causes in the foramen on the undersurface of the facet and the ligamentum flavum in that area. These symptoms will increase with extension. Generally, the causes which are anterior to the dural sac will decrease with extension. I'm talking about stenosis. I'm not talking about disc herniation. And I think these two distinctions have to be understood better by referring to the literature in more detail with more concentration. Now we'll come back to Karthik and ask him to give some of his comments. Karthik, can you please, I'm unmuting you, and will you please start your video again and yeah, have your comments on whatever we have just mentioned.
I think you've been very, very elucidate in detailing what has been what we all have heard you've been talking about for the last so many 10, 15 years. At least I have listened to you for the last 15 years, at least I think now. Now, I think the important thing take home, I think, is that the perception of the posterior alone being the causalgia of lumbar canal stenosis has to be taken out, in sense like you cannot say the flaval hypertrophy, facetal hypertrophy, and foraminal stenosis. These three are the only factors which cause lumbar canal stenosis as a presumptive thing which we have thought about traditionally has to be thought about in a different, or what we call as a global perspective now.
Yeah.
And I think, as you very rightly said, and as you all know, when you operate, you find the central portion actually is devoid of the ligament and flavum when you look at it anatomically.
Yeah.
And
Yeah.
that again goes back to your premise, which says that the central portion is not the true stenotic as opposed to a congenital stenosis like an achondroplasia, etc.
Yeah.
Now, going back on to redefining it, how much can we redo the lateral recess stenosis and then relieve pain is what we are looking at in terms of doing transforaminals. We've been doing transforaminals, and I think I still have not mastered the area where I could do stenosis decompression because, as Janmajay said, I don't have the requisite tools. And I think it's very important for us to rethink on those lines so that we could go away from a routine instrumentation, which is not, I think, absolutely required in all the instances.
Yeah, in that, Karthik, I'll just have one comment. And good that you brought this point, because we were hoping to discuss this point in more detail with all of you who are doing more of posterior midline or interlaminar surgery. Is very simple. We do a simple project where we do a surgery simultaneously through the foramen and through the posterior midline interlaminar. And we try to see where you go when you are doing a medial facetectomy in whatever way you do. And we do it through the foramen. I mean, try to reach the same area through the foramen and try to demonstrate that we are able to, we are not able to, etc., by doing what we do. And the same thing we will do the other way, that is the posterior midline interlaminar axis going towards the upper foramen, where people are nowadays talking of going over the top, etc., and undercutting the facet, etc. And that is a domain where we have been landing every time when we do the transforaminal. So we will be putting our scope there. You do the over the top surgery and try to do what you feel is correct. We will sort of observe it from the foramen. And then if we feel that what you have done is adequate, we record it that way. If we feel that what you have done is not adequate, we will do the further part of the surgery to make it adequate, so that we will have two clear guidelines. Number one, a medial facetectomy done by posterior midline interlaminar access through the foramen and trying to reach that area of medial facetectomy. Number two, upper foraminal over the top surgery by posterior midline under the facet or over the tip of the SAP, and transforaminal surgery over the tip of SAP, which we have been doing a lot of times. So maybe these two projects can be taken up. I would certainly like anybody of you who is interested. What we can do is you can put maybe even one or two surgeries are enough for this demonstration. We come to your place with our instrumentation and we do our job, the transforaminal one, or we do the other way. We put a case for you in our setup. We do our job. You join us, do the posterior midline interlaminar, and let's sort of compare the notes. I mean, that will once and for all clarify this matter. Of course, in addition, we are doing the same thing in near future on cadaver cores, and we will try to clarify what is the adequate thing, what is the right thing to do, or what is the, let's say, thing which is lacking. Is there any scope for improvement on either side? So that will probably improve our dialogue, that will probably improve our understanding, and that will probably put the precise use of implants and precise use of fixation, rather than being little liberal about its use today. I'm not talking about listhesis. I entirely agree that if you have a mobile or an unstable deformity, or a deformity which is pure, causing a narrowing of the foramen, etc., you definitely need a fixation, or maybe a transpedicular fixation. We can talk about the fixation later on, because this series of talks on stenosis are not over. It's a huge topic, and the only clarification which we are trying to do is our understanding has grossly improved, and we need to talk. We need to sort of exchange our ideas. We need to exchange our perspectives. So good. What you said, yeah, go ahead.
Can we quantify this on a pre-operative basis by doing a CT MRI studies, both from the canal point of view as well as the recess dimensions, to see whether it extrapolates with what you're discussing. Is
We
there
have
a role
already
for doing
done.
that?
I can send you some papers or some data which will clarify this question which you had, but there is no harm in doing it again. I mean, we can always do a study of, say, 5 patients where all their CT, MR studies are done. The problem is, all of us know that the image alone does not decide anything. And in some of the images, the symptoms and the image does not match. In some of the images, in fact, the literature says that the severity of the changes in the image necessarily is not severity of the symptoms, right?
Correct.
The foramen will look almost closed, but the patient may be probably partly or hardly symptomatic. So there's a lot of gap there in the understanding of the image symptom correlation. But definitely the point is well taken that we can do this study and we can then talk about the clearance, what we can achieve by posterior midline open, under lamina or interlaminar, transforaminal, and of course combined.
Yes, I think that's a very good project which is talking about, and I think we should definitely look at least 5 cases. And I
Yeah.
would definitely, once the COVID scenario changes, I would definitely look at collaborating with you on that.
Yeah, sure. You're welcome. We definitely want that. And as I mentioned some time back, even if you are also ready to support us in the non-operative program, like
Yes.
using the blocker to couple of patients, not hundreds, maybe 5, maybe 10. It is just putting the blocker on the patient and measuring the distance for 10 days before and after and coming out with the primary study which we have done tells us that this may help. This may help them in having some improvement. And well, we are learning. Let's say that we are not emphatic or dogmatic about it. We are not saying that this is the only way it can be done, but there is one way of conservative in addition to epidural steroid or peridiscal or perineural steroid. Now, some more comments from Girish and Neeraj and Laukush and Ravindra, and I think Pawan, Rajendra is also here. So I would like to listen to you, and all of us would like to know your perspectives because all of you are active and you have been doing these surgeries. So I'm sure you will have your own ideas and perspectives on this. So we start with Girish, then we go to Rajendra, then we go to Pawan, then to Janmejay, then to Ravindra, then to Neeraj and Laukush. Yeah, go ahead.
Sir, thank you. Thank you so much. What you told, sir, basically.
No, you're, yeah, okay.
I have done some series.
Louder, please. Loud.
Am I
No
audible?
sound. Yeah, okay.
Am
Okay.
I audible? Yes, sir.
Audible,
So
but
basically,
it's low. Please raise the volume.
sir,
But
I
go
have
ahead.
done,
Let's see. Yeah.
yes, sir. I have done surgeries and the transforaminal as well as the posterior, and I have the good steps about that. The transforaminal, when the ligamentum fem hypertrophy at the transforaminal area, really it affects. And when do the surgeries, I have done one case by the transforaminal as well as the posterior. So I will try to find out more things what you told us.
Yeah. Yeah,
Yes,
no
sir.
problem. What you could do is probably the next meeting when we'll talk about ligamentum flavum, you can show your perspective, the transforaminal perspective and interlaminar at the same time, so that we'll be able to understand that process better. Okay, now you want to add something or we go to the next person?
Yes, sir. Over to another person.
Yeah, okay. Rajendra, what is your comment?
Can you hear me?
Yeah, sure.
First thing regarding this app, it clearly objectifies, the recovery, the improvement. It was just subjective by the patient. This clearly would objectify what exactly you are working on. It gives you a tremendous confidence on the patient itself that he has remarkably improved. So we need to work on this to objectify our treatment program. That is one. Two, improving on the clarity of when one should operate. Where one should convince the patient of the necessity of surgery to prevent further damage. In a conventional, usually during the conventional follow-up, we never do the sonography for the residual urine, and we never work on the bilateral lower extremity symptoms, thinking on a coda equina-like syndrome. We just understand this is a bilateral claudication symptom for a spinal canal stenosis, not taking it into a serious perspective that it is almost similar to a coda equina, and one should sincerely work on it, get the details, and then talk it out to the patient about the prognosis.
Yeah.
I think these two things have been brought up very, very clearly. And finally, how one should look at the MRI, how one should look at the patient when he's examining, and what exactly is troubling him. Where should be your focus of treatment? Where should be your focus of block if you intend to block? And what could be the reason, anterior or posterior or lateral, have been much, much more clearer now. I really, honestly,
Yeah, I would.
Yes. Honestly, thanking
Go
you
ahead. Go
again.
ahead.
So I think people now will be more clear, They will just not take it for granted. Everything ligament level. Everything is stenosis is ligament level.
Yeah.
That's how the thinking is conventional. Today now, after those who have been listening to you, would definitely look for the anterior part. They will look for the lateral side. They will look for the posterior lateral side, where exactly looks like. And if I intend to give a block, where should I give a block? Should I go on the upper side? Should I go on the lower side? Where should I try to focus my diet going inside? I think it was much, much clearer, much different, in a very different perspective, where one can objectify very clearly.
Yeah. I have one more comment there. All of us know that when we are dealing with lumbar canal stenosis, it is almost always to do with L5 root and S1 root. So theoretically, we are dealing with lower portion of L4-5 disc. We are dealing with the exiting nerve L5 at L5-S1 foramen. We are dealing with traversing part of S1 root in the L5-S1 area or L5-S1 segment. And we are dealing with the lower portion of S1 or L5-S1 foramen towards the lower notch. So theoretically, our surgery is not a huge surgery. It is located to these 1, 2, 3, and 4 areas, about which we'll talk in subsequent details. Now, the next person to be asked to give comments is Pawan. What are your comments or anything which you want to ask or suggest or say in the matter? Dr. Pawan Kohli? Hello, Pawan. Are you there? I think he is not there. So now then we will go to Laukush and then come back to Ravindra. Okay, Laukush, go ahead. Not audible. Raise your voice. Not audible. No, not audible. Maybe you may have to test your mic. No, you're not audible. Yeah, okay, you can type. I can read it. So Laukush is typing and he is saying, yeah, go ahead. In the meantime, I'll check the second screen because I have probably missed some people. Dr. Palani is there. Dr. Anil Sangli is there. Dr. Yoganandan is there. Karunakaran is there. Amit Surana is there. So Vyapak Podel is there. All of you, please have your comments ready so that you will get the next chance. After Laukush is Ravindra, then Neeraj, then we go ahead one by one. So okay, dealing with stenosis is little difficult. First thing is diagnosis, start with conservative according to symptom. Yes, agreed. Then, what is your comment on the intervention, the timing of intervention? Okay, then symptoms are aggravating, then you would like to intervene. Okay, I'll prefer transforaminal. Okay, very good. So you will have to justify that by your voice typing. Maybe somebody else is typing for you. So, okay, you did interlaminar, and what was the experience? Results were good, that for bilateral symptoms. Okay, perfect. So what I would suggest you is that results were good for bilateral symptoms is noted, but then did you do the same surgery on both sides, or was it less on one side, more on the other side? And could you have done it in stages? Did you do it under local, etc.? So those questions we'll take later on. Now we'll go to Ravindra, your comments, then we go to Neeraj.
Yes, sir. Thank you, sir.
Yeah.
Now, the first two generations of endoscopy, development of endoscopy procedures was to do with disc-related problems, and the third generation deals with canal stenosis, lateral as well as lower canal stenosis. And we had started off with endoscopic pulmonoplasty, but now with more inputs, I feel we need to expand that horizons of pulmonoplasty. Initially, pulmonoplasty, we used to concentrate on the supraortic process and the ligamentum phloem extending from there up to the pedicle. But now, I mean, we basically used to deal with the superior portion of the foramen. But now, with other inputs as well, I think we need to look at the inferior portion of the foramen as well to deal with the traversing route. So, tackling the exiting route as well as the traversing route through the foramen to the transforaminal route, working on the upper portion as well as the lower portion of the foramen, should solve the symptoms of the patient. And as we do more and more of these surgeries with developing more expertise, and definitely I think we can give better results to the patients. And as you said, we should always compare that with a midline surgery, maybe done through a UBE or a PSLD. I mean, that also can be tried. And over a period of time, maybe 6 months down the line, we should be in a position to say that we should have all the guidelines in place to say that this works. The transformal route decompression of the foramen itself is enough to solve the symptoms of the patient.
I think the problem is for us to choose a particular treatment modality for a particular patient. The numbers which we treat individually are not very big. So we may have to do a collaborative sort of thing where we follow certain guidelines and each one contributes one or two cases or some cases where some more maturity to the guidelines can be given. That point is well taken. I have noted that. Now we go to Neeraj, and Neeraj, what are your comments, suggestions, observations?
My observation is a little lengthy, but I'll just take a minute or two.
No, you take your own time, no problem.
Thank you, sir. So I started my disc procedure about 13 years back, mostly percutaneous, So, but lately for last 7-8 years, I've started doing endo procedures. I've done 250 plus. But initially when I started, I was doing the easy disc, Then I started getting bigger disc and all those migrated discs. And, with more advent of expertise and training with you, we can really tackle those difficult disc syndromes also. But lately, what we're getting is we're getting a combination. We don't get a pure disc, in most of the patients. We do have a combo of a disc with a canal stenosis, maybe some soft tissue, maybe some hard element also, some bony stenosis also, whereby just tackling the disc part really does the justice to the patient. But more and more we're getting canal stenosis, more and more bony stenosis is the time we go for a stenosis surgery, like what you really taught today. Yes, Gore hook was a very, very big advantage in those difficult times, and even today for the difficult disc syndrome where the migrated disc are there in epidural space. So we're not worried about. We can do a lot of those discs transfemoral without any big worry. Now coming to the, lately I have a laser on me, so that is really helping me for the foraminoplasty. Very, very big help. Putting laser around what you said is the RF, which is coming. I'm waiting for that, and it's a very big thing. It came from China, probably it is in India also now. It is going to be very, very big help tackling those soft tissue, even the little harder soft tissue also sometime, which is difficult to handle with the plain cautery. So here, your cautery and sometime laser, which you have and I have, is a very, very big help in those tough situations. You can really take care of those foraminal ligaments and foraminal calcifications and other things, which they come up, and you can handle that. And with obviously with the bony stenosis, sometimes we have other techniques whereby you can do a facetectomy and proceed. Mostly is good for most of the patient. Rare would be the patient who really need some more work, whereby you really have to take the posterior element into account, or there's a massive ligament hypertrophy where posterior element is really required. With your expertise, you can do anything from the transversal area, but with other people, it's really going to take some time before they really reach that expertise. They can do everything from the transversal area. They are taking help of the interlaminar window also, and as it is also developing by itself, UB and other things are coming up. But I think over a period of time, people have to be understanding whatsoever you do, you expertise on that. Only then you do it. You should do justice to the patient. End of the day, patient has to be asymptomatic. What you've been teaching every day is the pain is the main problem where patient come to you with, and patient has to go away pain free. That's the whole idea of doing everything. I do add here that sometimes we have other allied reasons for the pain like facet and other things. We should look into that and try to treat that as well for a wholesome or 100% treatment of the patient. That's my call, sir. Thank you for giving me time to speak.
Yeah. Okay, now we can go to who do I see here? Dr. Vyapak, you would like to have comments? Please go ahead. Yeah.
Thank you, sir. I'm actually from Nepal. Thank you for your good lecture and discussion. I'm also along with your teaching because in the lumbar canal stenosis, the main symptoms is not the radiculating pain. It's either the neuropathic pain or autonomic pain. So the issue you have raised, that ligamentum flavum, the anatomy, and its expansion is very, very important. And so the primary treatment, first treatment is to treat conservatively, either by because of this there is an inflammation and the mechanical compression over the nerves root and also the cord. If according to you also, I also believe that this in lumbar canal stenosis, this stenosis either from the anterior side or from the lateral or from the posterior itself, but not the central one. So mostly is anterior is either from the osteophytes around from the end plates or the disc herniation itself. Anterior. In lateral, we have the lateral recess and we have here the facets because of the fascial hypertrophy and the osteophyte formation and sometimes the subtle immobility of the facet that can lead to the dynamic compression over the foraminal itself.
Yeah.
And the extent of the ligamentum flavum that extend upwardly to the pedicle, as you said, that is the main culprit because the pain, the symptom that arises distally is the neuropathic or claudication. So we have to tackle either on the cord side or through the exiting foraminal root side. It's not a radiating side because mostly traversing root, when there is a compression of the traverse, it gives the more of the radiating type of pain. So stenotic pain is mainly because of the compression to the cord or the exiting root. So our main focus should be over that elements.
Yeah, perfect. We agree. I think um, the more point of agreement would bring some uniformity in our approach to that area. Initially, probably it will be both interlaminar and transforaminal, but let's see, we can slowly push each other into our direction and try to cover the overlapping areas. Now, I have requested Dr. Mrutyunjay from JSS. Ravindra, I think you're also there. So I would like to have his comments, because you see, our forum is not necessarily only about endoscopy. We would like to learn the science behind our actions. So, Dr. Mrutyunjay, please, I would like to listen. All of us would like to listen to your comments on this.
Thank you, sir. Thank you for inviting. So actually, I have the main concern regarding the mechanism, why the hypertrophy happens, why the hypertrophy of the facets happen, why does the capsule becomes lax, and why does the synovial gets hypertrophied. So what causes, what is the primary problem? And then which leads to spinal canal stenosis. I think we have to address that one. So maybe the mild instability, which is going to be there to start off. So why that instability? Is it an extra spinal? So is it related to the hamstrings which are tight? So is it related to the abdomen which is becoming lax? Or is it the retrospinae which is not so strong enough to stabilize the spine? So primary cause could be something which is extra spinal. So need not always be spinal. So first we have got to tackle that one. And then once we stabilize it and then try to get the strength of those structures, then because the getting them to the proper strength is much more important even after surgery. It is not just doing surgery. So post surgery, so those primary problems have to be given some importance. So before we just do what has been already spoiled. So that means the whole thing has become stenosis. And what has caused stenosis? So if that could be addressed, because primary cause has to be evaluated and then addressed even after the surgery. This is what I feel actually.
Yeah, I will have one single comment on that. The comment is like this, that all of us are seeing patients at various stages of degeneration. And as we know, traditionally, we have been calling it a stage of dysfunction, instability, and stabilization. And some of them in those stages are symptomatic in different ways. In stage of dysfunction, they cause herniation with sciatic pain, etc. In the stage of instability, probably they may have some claudication off and on, which may stabilize automatically over a bit of time. And then they may go on to a stage of stenosis, where they come back again with claudication of a different variety, of a different cause. What I feel is, as clinicians, what you said is absolutely important. There's no question about it. But since we are seeing the end result of the process, probably the time has gone when we can sort of go back. I mean, it's like putting the time machine and taking the patient back, say 20 years or 15 years, and then saying that, okay, now we have brought you back to this stage where your symptoms are not there. That theoretically we are trying to achieve by surgery, by just trying to make the nerves free so that the function of that axilla, the dorsal root ganglion, and the traversing nerve improves. We don't really know whether what we are doing is adequate or not. That is another question. But your point is very important. I do agree. In fact, what is going to happen, I will tell you. When we started endoscopy for the disc, there was a strong objection by a lot of my friends who are from the traditional side, saying that, Dr. Gore, you are applying surgery very early to the disc. I mean, I started operating patients who had a lumbar disc annular tear only with trap fragments. There was no herniation. And we started treating them even at that stage. So treating people quite before the traditional indication stage started with better understanding. It may happen, and it has already happened. I'll tell you interesting thing. What has happened is, a lot of my colleagues who do transforaminal endoscopy, they are very aggressive and they treat the canal, the subfacet area, both upper and lower, even on the day when they treat the lumbar disc herniation, saying that this way I will prevent the early occurrence of claudication. I mean, they have understood that they are catching that start of the change on, let's say, today, rather than the patient coming back after a few days or few years, etc. Of course, we can always debate on this, whether it is right to do it that time, whether by ethical standards you should wait for the symptoms to worsen, etc. But that is for another day. So we will now probably go ahead with Dr. Yoganand. Would you like to comment? I saw your written comment that you have not done transforaminal surgery. Now, there are people here on the screen whose names I don't see. So I'm not able to invite them specifically by name, but we are open. Anybody wants to give a comment, please unmute yourself and give a comment. Dr. Anil Sangli, you're also welcome to give a comment. Dr. Vishnu, you're also welcome to give your comment. So please, we have maybe another 10 minutes before we stop. It's almost close to 2 hours now. So please go ahead with your comment. We are all listening to you. Amit Surana, would you like to comment? Dr. Anil Sangli, yeah, please go ahead. Your turn.
Good evening, sir.
Good evening, yeah.
It was a very nice discussion. The thing is, I've been doing some transforaminals now, and with the help of Dr. Ravindranath, and a few of them independently also. What I've found is the problem with me is a little bit of this material probably will be left behind, and the patient may come back after about probably 6 months or a year with little bit of symptoms again. And I would like to know whether we need to go again and do there will be, if I do a repeat MRI, which I've done in about 2 or 3 cases, there is a little bit of a fragment of a disc. Probably the angle which I go may be different, or I may not be able to address the disc which is exactly pressing on the traversing or the exiting nerve root, or some fragment may be left behind, probably because I'm new and I'm not very sure whether I should be going in further, or the end point of my removal should be probably fine-tuned. And with respect to the canal stenosis and other things, what I came to know just now is the extent of the ligamentum flavum extending onto the pedicle. That honestly, I was not very sure of it, and I am very enthusiastic to know and see how exactly that relation comes in at the region when we are doing the cadaveric dissection. So we can have a very good perspective of what exactly the point is, and our anatomical three-dimensional orientation gets better, so we can address the patients better.
Yeah. Now, regarding your first question or your concern, I would just give you 2 quick tips. Number 1 is the angle at which you come for the herniation. You must always remember that the symptoms are caused by posterior annulus. So you're going at the center of the disc in lateral is not necessary. You have to be below the annulus. Then you have to tackle all the trap fragments of the nucleus, etc., and see that the annular tear is clean so that it heals well. Number 2 is whatever way you do the surgery transforaminal, you must close the opening in the annulus by use of a platelet-rich fibrin plug. The moment you start closing the opening, there will be a drastic reduction in the recurrence of symptoms. Number 3, you may have patients who may have recurrent symptoms only, and the pathology may not be recurrent. What I mean is the symptoms may be just chemical, in which case just a distal block should be adequate. Yes. And number 4 is actually what has happened, as all of us know and understand, is that surgery, unfortunately, we don't learn by or we teach by holding somebody's hand. It is your haptic inputs, it is your ability to sort of correlate the feel, the patient's inputs, the inflammation, etc. So some initial learning curve will always be there before you are much more perfect in doing what you are doing today. What I would suggest is very simple. One more is that post-operative images, again, you may have to sit down with the MRI fellow and tell him that unless you know what I'm doing, please do not comment. Because the printed report goes to the patient and there is unnecessary bad blood between the patient and the surgeon, because the patient only talks or reads the report. It doesn't mean anything. So you have to sit down with the MRI fellow and tell him that please understand that when we do our surgery for disc herniation, many times the annular shell will look the same, no change, but the inside of the annular shell will be empty. It will be white. It will show an empty part of the annulus where we have removed the fragment, and some recurrence of inflammation is known. If you're doing a scan without GADO or any other enhancement, talking about inflammation is impossible. So all those comments on a post-operative is fine. In fact, I have planned one more meeting, maybe down the line in coming few days, on post-operative imaging of the spine. It's a huge subject which has a lot of misconceptions which are promoted by the imaging specialists. And I nowadays I have started telling the patients like this, very, very specifically. I said this imaging person has never ever in his whole life seen a patient, diagnosed a patient, operated a patient. He is a person lost in the realm of shadows. I don't give a damn to what he has written. I would like him to come in front of me and say this, what he has written. Then I will tell you what it means. I mean, their reports are only one side of the story. So we need to be a little more observant about correlation of pathology, symptoms, and image. So that would clarify that. Now, there are multiple comments here in the chat, which I'm reading, and let me see. So, the comment is, oh, it's, okay, the last comment is very big. So, okay, somebody is saying, I mean, this window is difficult to navigate. Okay, some finer aspects of stenosis. I've tried both transforaminal and interlaminar. Till date, I found transforaminal more satisfying, but the challenge is 5-1 with high iliac crest. That is where I choose interlaminar, but still a little confused about clearance of foraminal component. That is the only time I'm trying transforaminal. Interlaminar. If you can throw light on how to handle 5-1 with high iliac crest for stenosis, that would be great. Okay, I understand. What we will do is we'll probably be talking about 5-1 stenosis later on, but I'll have one single comment for you. The comment is 5-1 is ideally suited for transforaminal surgery for stenosis, mainly because you come below the facet. You can clearly clear the subfacetal problem. You come below the pars most of the times, and it's very easy to go in the lower portion of the foramen, the lower notch and the lower aspect of the lateral recess. So more about that probably in next meeting. So I think we should conclude now. It's almost 2 hours, and there are a couple of you who would, I'm sure you would like to comment, but please reserve those comments for the next meeting. We will have a detailed meeting for at least 2 hours on just ligamentum flavum. Okay, I will fix up the date, probably Thursday, probably same time, 2 p.m. But I'll confirm by tonight or early morning tomorrow. It will be a meeting only about ligamentum flavum. And Karthik, I invite you. I would also like all your colleagues, students, or associates also to join, because I feel this topic needs further clarifications, which is sadly lacking today. And I feel that most of us who are comfortable with what we are doing, we just continue doing what we do because we are good at it. But there is a scope for questioning, repeatedly questioning whether what we are doing is correct, adequate, proper, fine, etc. So let's do that in the coming meeting. So thank you very much, and welcome. And all of you can join for the next meeting. That is ligamentum flavum alone, only about ligamentum flavum, so that we will have some more clarifications. I'm also trying to get, as Dr. Pratyunjay mentioned here, I'm also trying to get some imaging fellows to join and comment on the ligamentum flavum from their perspective. I have in fact asked one of the imaging fellow to bring some of his MRI images and explain to us what they look at. So we will be probably finding some areas of controversies or finding some areas of agreement. Let's see. So thank you very much, and welcome to our next meeting. In the meantime, I say bye-bye and thank you. Let's see you next time. Okay, bye.
Thank you so much, sir.
Yeah,
Bye-bye.
thank you very much. Bye-bye. Welcome.